So we're going to start with a case study for this makeup that we have to do here. It's going to be a call that I ran. We got called out for a 65-year-old male, and he was complaining of heart palpitations. It was about 2 o'clock in the morning, but whenever we arrived, it was a nice house. It was well kept. There's no reason to think that he was being abused, nothing like that. It was safe. The fire department was on scene whenever we got there, and his wife and some of the kids were also there. So when we arrived, he was seated in a living room chair. Fire department and his wife were close to him. His skin was normal. He was breathing normally, and he was seated normally. So there wasn't tripod or anything like that going on. He was alert. I asked him the ANO4 questions. He could answer all of them. I didn't see any immediate life threats that would concern me with this patient. He could talk to you. His airway was patent. He spoke in complete sentences. He was eupnic, uh, breathing at the normal rate. It wasn't labored at all. It was a good normal depth. He wasn't shallow or anything like that. So just a normal depth. His skin was normal. I didn't see any blood around. So when I took his pulse, his rate was normal. It was +3 in quality, which is normal. It means it's a normal strength pulse. And it was also regular, so it wasn't like AFib or something that I could feel. So after this was our transport decision. So with a patient like this, it seems like it's a pretty good candidate for a sort of stay and play. So went to the secondary here. He said his symptoms had resolved, and the fire department confirmed that. He wasn't allergic to anything. He took one pill, let's say lisinopril, for high blood pressure, but otherwise he was pretty healthy. He was actually a 65-year-old retired police officer. The last time he ate was before bed. It had been about 6 hours because it was 2 a.m. whenever we got there. But this did wake him from sleep, these palpitations. So when it started, he was sleeping. He says everything had resolved now. He felt completely normal. So he denied provocation and palliation. And he said it lasted about 10 minutes that he had these palpitations. So a little further going into it, the patient's story here. He said he was basically asleep and that he woke with heart palpitations and he was also gasping. What he did basically after that was he shot up out of bed because he felt a little claustrophobic in the bedroom. And he came out to the living room where we found him and sat down. So just getting out of bed actually woke up his wife, who came to see what was the matter. And she's the one that called 911. The patient said he was actually diaphoretic when this started, but that had actually resolved by the time fire department had got there and by the time we were there. There were also no palpitations that we can hear at this time. And the fire department told me that the symptoms have resolved even before their arrival. And they were there maybe 2 to 3 minutes before us. The first pulse they got was actually 80 beats a minute. Also reported that it was regular. On the head to toe secondary, just some negatives here. JVD and tracheal deviation. He didn't have any retractions. There was no scar in the middle of his chest from a cabbage. Reported that he never had a stent before. His abdomen was soft and tender. Lower extremities weren't swollen, nothing like that. No reason to think he had CHF. I also took his lung sounds, and those were normal. As far as his upper extremities, the pulses were good, and they were actually equal on both sides for his radial pulse. So on vitals, his heart rate was 80 beats a minute. I didn't actually put it on here, but his blood pressure was normal. It was going to be something like 130/90. It wasn't bad. He was breathing at a normal rate with good SpO2 on room air. I went ahead and did a finger stick. That was normal as well. Let's say 90. So So I hooked him up to a 4-lead EKG. He was in a normal sinus rhythm. It wasn't fast, anything like that, just a normal rhythm. So I did a 12 lead on him. Just suffice it to say that it was normal. I didn't see anything like signs of pulmonary embolism. Couldn't see anything that would indicate that it's a heart attack or something with electrolytes. Nothing like that. So it's time to kind of move on to our field impression here in the differential. So to keep it kind of sufficiently big enough, wide enough that we can consider all the things, let's just say that we're just looking for a male. It doesn't have to be exactly this patient, but any male that has cardiac palpitations, what can be the cause of that? So I would tell you it'd probably be a good idea to go ahead and just try this on your own before I show you, and I'll give you a couple seconds here and see what you come up with. Okay, so as far as the list goes, it's going to be your pretty standard stuff. It's going to be your heart attacks. Now, on the monitor, he didn't show one. Of course, it doesn't pick up all the heart attacks. You got to watch out and make sure this wasn't a pulmonary embolism. So, the most common rhythm for a PE is actually sinus tachycardia. So, kind of just a normal heart rhythm that's a little too fast, something under 100 beats, 150 beats a minute. We have to consider if this was just stable angina that will come up from sleep here. He's never had anything like this happen before, but still maybe. Pneumo could definitely be in the picture here. They will get higher heart rates, especially as obstructive shock kind of sets in here. Worry about pericardial effusions and tamponade, that sort of obstructive shock where their heart rate's going to increase so they can increase their cardiac output before they just decompensate. And the thing that we talked about on Tuesday in class, cor pulmonale, which is heart failure due to high pulmonary arterial pressures. Now, these cause the atria to actually get bigger, so it could be an instance of atrial fibrillation that we didn't catch before we got there, and it has since resolved. We got to worry about SVT. This could also cause him to wake up, and that can resolve itself. Because of his age, it's not as likely that he's going to have new onset SVT at 65. It generally comes in quite a bit earlier, but it is possible. And if he was a bit younger, we would include this ARVD. That's arrhythmogenic right ventricular dysplasia. That means that there are cells in his right ventricle that can actually create a heartbeat that aren't supposed to be there. Usually not in someone that's 65. This usually kills young people when they go into VTAC and eventually VFib and cardiac arrest. We should think about more simple stuff like gallstones, because the abdominal pain can cause him to have a higher heart rate, because when you're in pain, you have a higher heart rate. But he did say that his abdomen didn't hurt him. We got to worry about drug use, even things like too much caffeine, although he's been asleep for a while here. But the illegal drugs, things like cocaine and those sorts of amphetamine drugs. We would have to worry about sepsis, because if you get sepsis, you normally have a higher heart rate to try and overcome that cardiac output because everything is so dilated. Now, since he didn't have a fever and he had a normal blood pressure, this probably isn't the case. And then there's some more stuff, and that's probably what happened to him here. So if we're going to come up with a decent field impression, we're going to have to ask some more clarifying questions, just like it said in your book there. So he denied all the stuff that I asked him. He wasn't sick recently. He wasn't nauseated. Didn't think that he had a fever. His chest never hurt. He just had palpitations, and he says that's resolved now. So there's also one more clarifying question that we should ask in this particular case. So if we think about what he said, he woke up from bed and he had fight or flight because he tried to get out of the room. So he had an increase of epinephrine, norepi, which caused him to sweat and have those heart palpitations. So the last question I asked him was pretty simple and just kind of made sense with the story he had given me, and that was whether or not he snored. So his wife assured me that the patient did. So what I was thinking at this time was probably this guy had some sleep apnea, which caused him to stop breathing for a little bit, and that caused a fight or flight response, which woke him up. This is a story that happens all the time in people with sleep apnea, and they can't quite figure it out. But because he woke up gasping, that's a pretty good clue that that's what the problem is, especially if he has clear lung sounds, which he did in this case. So this was a refusal. Now you do have to go ahead and give him some advice here, and beyond just the normal stuff that if something happened, we're not going to be around to fix it. But he was 804 and he could refuse. So on these people, it's important to remember that what we need to do is be sure that they know that this is a serious problem and that he needs to contact his actually family physician in the morning and see what the doctor thinks, give him the whole story, and see if he needs to be set up with the sleep medicine specialist or he needs to be coming in to actually get physical and get checked out by the family doctor. So don't forget that last part whenever giving these people advice.